Assalamualaikum warahmatullahi wabarakatuh. Friends, Dato and Tan Sri, ladies and gentlemen. Today's contribution is on case history, a Sunday, September 11, 2011 contribution to Pearls and Jam. Case history. When I was a research registrar at St. Bartholomew's Hospital, London, some 4 decades ago, comes Fridays, we registrars on call for the weekend always cannot help feeling abandoned, and that familiar deja vu feeling of melancholia invariably seeps in. Why not? We could feel the rest of the hospital medical staff, juniors and seniors, already on the weekend mood. By 2 p.m., 50% already disappeared to some pubs somewhere near the biggest mid-market in Europe, that is Smithfield Mid-Market, around the vicinity of Little Britain and around EC1A area in central London. We can call those days were pretty long and lonely affairs, at least for me. Friday, Saturday, Sunday, and you see your bosses only on Monday morning. Of course, they are contactable, but the unwritten rule is, if you are worth your salt, you don't call them. God is there all the time, but you don't call him on Sunday. You are the substantive registrar and consultant, and you hold the fort. I find being the boss and coolie at the same time in a substantive central London teaching hospital, at my level of incompetence at that time for an extended period of 3 days, very daunting and stressful experience plus. Till Monday, you are the boss, lording over an active cardiac unit with your senior house officer and junior registrar, unless of course someone almost at the same level of the Queen of England get admitted at St. Bart's. Only then will you have the reason to call God. British medical consultants those days have a class and style of their own. In egalitarian London of the 80s, that would be rare. The Queen's Hospital was St. George's anyway. And I still think it's at the present time, though Prince William was delivered at St. Mary's Hospital, another hospital of mine before I moved to the more fashionable and more reputable St. Bart's. St. Bartholomew's, though in the city and surrounded by lawyers' office, barristers and Queen's counsels and brokers, are still working class, a wee bit stiff in the upper lips, but not yet quite enough. I would come on Friday morning with some gloom already working up in my head, with a big loaf of bread and a Tupperware full of my favorite dish, beef or mutton cuisine, cooked by my dear wife to cheer me up, nicely stored in the junior staff quarters refrigerator. The frozen cuisine will be cut a block at a time and defrosted for breakfast, lunch and dinner for the next 3 days. By Monday morning, just mentioned cuisine and I would want to vomit. They did serve steak, fish and chips at the cafeteria, but despite reading Hamka and all that, knowing that Hamka is quite liberal in this situation, I find these junks could not get beyond my glotis. St. Bart's is one of the oldest hospitals in London, if not the oldest. History has it that in those good old days, when the internist physician could not treat their cases of carbuncles, tumors and growth, they would refer these rather troublesome and embarrassing cases to the excellent butchers across the street, the Smithfield Mid-Market. The gentlemen of the night, by virtue of their working class standard, usually creep into the hospital and operate by night. In a grand round the next day, the internist physician would lord over their patient and claim the glory of success. That, I was told by a senior, was the beginning of surgery as a specialty. No wonder the British still call them Mr. and not the honorific doctor. Even now, years as a big-time consultant in Subang Medical Center, I still take weekend calls as a pain in the neck. 2 days, Saturday and Sunday, you find yourself unable to go anywhere or plan anything. I'm on this week. Just as I was about to go home for lunch, this 52-year-old gentleman, a Malay chap, supervisor at a factory somewhere in PJ owned by a multinational company, landed on our table, was admitted with central chest pain via ER and breathlessness of sudden onset. Risk factors: diabetic and hypertensive over 4 years with poor control and surveillance, and a smoker. Diagnosis: hyperacute phase of an inferior myocardial infarct. Standard operating procedure: admit for primary myocardial infarct angioplasty. Angiogram showed severe triple vessel disease with culprit right coronary artery totally occluded. I pass a guide wire across occlusion and aspirate the clot plus using an aspiration catheter. In the process, I lost wire access in the process and unable to rewire across the lesion due to the probable change in the plug configuration. No improvement to wire access even after a bolus shot of RealPro. 5 milliliter of this precious fluid cost more than gold. Last ditch effort, since life at stake, I add another 5,000 units of Metalase, a more expensive fluid than RealPro, given intracoronary. Wire still not crossable. Patient's hemodynamic stable though. MashaAllah, Alhamdulillah. 10-minute post-coronary infusion, another cine taken. The right coronary artery is still occluded. I call it a day since patient still stable and procedure already took 1.5 hours. On the way out of the theatre, patient had ventricular tachycardia and ventricular fibrillation. That is, patient had a cardiac arrest on the table prior to transfer to CCU. Patient was duly defibrillated successfully. Alhamdulillah, this is a good sign of delayed recanalization by chemical fibrinolysis, I told myself. Totally dead muscle usually are required. Semi-dead muscle due to microcapillary recanalization, fibrillate, and thus has reperfusion arrhythmias such as VTVF, needing even defibrillation. That is electrical shock. My cath lab staff went blue. I pacify them. Don't worry, dear. This is a good sign. You guys will see him Monday, inshallah, I told them. Today is Sunday. Patient in CCU stable and well. My plan was to do a check angiogram tomorrow, expecting to see some reopening of the occluded right coronary artery. A check coronary angiogram this time to prepare patient for possible bypass surgery in 2 months' time. If the right coronary artery reopens somewhat, he goes for bypass. If not, we'll have to optimize his medical therapy. We seldom refer patients for bypass these days, unless they need at least 3 vessels to be bypassed. Sunday, just now at 5 p.m. got called by Dr. Shu, neurologist on call to see a young Indian girl, 32-year-old with idiopathic thrombocytopenic purpura, which is a severe dysfunction and reduction of platelet due to unknown causes. Patient was moribund, in coma and fully ventilated in ICU. Her BP is on the floor with a systolic 50 and had a run of VT. She had earlier been on state-of-the-art therapy under hematological consultant who successfully upped her platelet to almost normal count. Today brought in with severe headache and shortly after admission had massive intracerebral bleed, needing to be ventilated in ICU and in deep coma. Urgent referral plus. I gave an over-the-phone order. Intravenous bolus Xylocar 100 mg given stat. Intravenous infusion of dopamine and noradrenaline. The BP normalized in 10 minutes to 120/70. An earlier MRI brain showed huge 6 centimeter diameter intracerebral bleed in the motor cortex of the brain and building bigger with time. With stable hemodynamics now, we needed to bring in the prima donna, the surgeon. The neurosurgeon on call still busy operating in the theatre, so I got to call the second neurosurgeon. The second neurosurgeon in KGNS improving his golf shots. He has to come in and decompress the brain right away. Otherwise, this nice looking young girl will not survive the night. And given the bleeding tendency, she may not even survive at all. It is Hobson's choice. But what choice do you have when faced with a young 21-year-old dying due to a burst and leaking pipe in the brain and a bleeding disorder problem? Reminded me of this poem we Standard 6 children of the past memorized by heart. Was it by Anonymous or was it by William Henry Davis? I've forgotten. I think it must be from Davis. What is this life? Full of care. We have no time to stand and stare. No time to stand beneath the booth and stare as long as sheep or cows. No time to see when woods we pass, where squirrel hides their nuts in grass. No time to see in broad daylight, streams full of stars like skies at night. No time to stare at beauty's glance and watch her feet how they can dance. No time to wait till her mouth opened and reach that smile her eyes began. A poor life, this is full of care. We have no time to stand and stare. Postscript, Monday morning, 7 a.m. The young girl had emergency burr hole and decompression surgery done late last night. This may not even be helpful for her as her BP plummeted down this early Monday morning to unrecordable despite being on full dose triple anethrope. I do not see any prospect of survival. Primary physician, the hematological consultant, discusses and explains in length the grave prognosis to the close family. Again, an example of the transience and the fragility of life. The 52-year-old diabetic factory supervisor survived the weekend very well, and check angiogram done at 2 p.m. today showed recannulated right coronary artery. I resisted a natural urge to just dilate, balloon, and stand this lesion in view of the fact that his left system is adequately diseased as well, though not totally occluded. He is planned for bypass surgery in 4 to 6 weeks' time. Bismillahirrahmanirrahim wa mursaha inna rabbil ghafurur rahim. Surah Hud, ayat 41. In the name of Allah, be its cause and its mooring. Lo, my Lord is forgiving and merciful. Assalamualaikum warahmatullahi wabarakatuh. Till we meet again.